Session 1 is really about the fact that there is a donor for everyone. It's not all about cord blood, it's really about the patients we serve and about having the right donor for that patient. And in 2024, there is one for everyone. And then very quickly, because I think this wasn't in your slides, Dr. Menes, this is just the speakers, and then which you'll meet, and then their disclosures. Okay, and I'm going to hand it over. Thank you.
Thank you very much. Good morning, everyone. I really want to thank the CBA for this invitation. I want to thank you all for being here, and it's my pleasure to introduce my colleagues, Dr. Politicos and Dr. Goptu, who will be joining me on this first session of the day. There's a donor for everyone in 2024. Okay, I'll ask Dr. Politicos to join us. Thank you.
Thank you for the introduction. Good morning, everyone. It gives me great pleasure to be here today, and I hope that everyone has a nice meeting. In my talk, I will try to show that cord blood is a valuable stem cell source, and in certain cases may in fact be the preferred stem cell source for our patients. These are my disclosures. The likelihood of finding an 8 out of 8 matched unrelated donor in the registry is influenced by the patient's ancestry. The majority of non-European patients have less than 50% chance of finding a full match in the registry. Moreover, the availability of matched donors is even lower for minority patients. In addition to that data from NMDP that modeled the likelihood of finding an 8 out of 8 unrelated donor, at our center we have looked at the likelihood of patients actually undergoing a transplant with a fully matched donor by their ancestry, and also stratified by an earlier era and more recent era. Similarly to the previous study, we observed that the majority of, we observed that patients of Southern European and non-European ancestry had less than 50% chance of actually undergoing a transplant with a fully matched donor. And moreover, the improvement over the early era, which is color-coded in red, and the more recent era, which is color-coded in blue, was only modest, which suggests that disparities in access to fully matched donors, especially for minority patients, persist. So such patients who do not have readily available matched-related or matched-unrelated donors can be served by alternative stem cell sources, such as cord blood. And in the next several slides, I will highlight some of the unique attributes of cord blood that, in my opinion, make it an attractive stem cell source. Firstly, cord blood extends transplant access to patients regardless of ancestry, and that is because of the reduced stringency for HLA matching. This is shown here in this pie chart of 319 patients who received a cord blood transplant at MSK. And as you can see, all ancestry groups are fairly equally distributed. Secondly, cord blood can facilitate rapid transplantation. This is a nice study that Warren Fingru did at our center, where he captured patients with AML at the time of diagnosis and analyzed the time to BMT consultation where the indication for transplant was established, and also the time to transplant stratified by patient ancestry and by stem cell source. As you can appreciate, both for Europeans and non-European patients, those who received transplant with a cord blood, shown here in red, had similar time from allo indication to allograft to those patients who received the transplant with sibling donors. In contrast, patients who received transplants with alternative adult donors, such as haplo-identical or mismatched unrelated, had delays to time to transplant, suggesting that there may be problems with either donor availability or donor attrition, sometimes multiple donors needing to be worked up at the same time. He has also, in another publication, Warren has shown that some of the adult donors that especially non-Europeans get are either older or more mismatched compared to the European ancestry patients, and these donors are considered less optimal. So I think it is fair to say that cord blood can reliably provide rapid transplantation, especially for patients who have high-risk disease and may need urgent transplantation. Thirdly, I think it is important to note that cord blood can be associated with good outcomes, especially in patients who have high-risk diseases, provided that some modern practices are followed. Many centers can achieve very good outcomes. Here I will highlight our preferred platform at our center, consisting of an intermediate intensity conditioning regimen, GVHD prophylaxis of cyclosporin MMF without serotherapy, and a double-unit cord blood graft. A few years ago, we published a series of 90 patients who underwent a transplant with this platform. They had a median age of 47 years. Half of them were non-European, and the most common indication for transplant was acute leukemia. We observed high rates of engraftment of 98% at a median of 22 days. The rates of grade 2 and grade 3 to 4 acute GVHD were relatively high, particularly for grade 2. However, we saw very low rates of chronic GVHD by the stringent NIH criteria. And despite those high rates of grade 2 to 4 and 3 to 4 acute GVHD, we had an acceptable 3-year TRM of 15%, and the relapse rate at 3 years was 9%, which is fairly low. Consequently, the 3-year overall survival and progression-free survival estimates for this cohort were 82% and 76% respectively. And an important observation of this analysis was that a higher CD34 cell dose of the engrafting unit was associated with reduced risk of mortality. And this may have implications in terms of how we select grafts in order to try to further improve outcomes for our patients. Another important finding was that the HLA disparity of the engrafting unit to the patient was not associated with a negative impact on outcome, which is also important because it would suggest that we can use mismatched units to serve our patients. The fourth characteristic of cord blood as a graft source, which is one of my favorite topics, and I will spend a little more time here presenting data, is association with robust GVL. There have been several retrospective studies suggesting that showing a lower relapse risk with cord blood compared to other graft sources, although some other studies have shown conflicting outcomes, and that is perhaps because of some confounders, and I will try to cover some of those in the next few slides. It should be noted that reduced relapse risk has been more commonly reported in double-unit cord blood transplantation series, and also it has been less commonly reported after non-myeloablative conditioning or series that used ATG-based GVHD prophylaxis. I will show some of the data supporting the robust GVL. Claudio Bronstein in 2010 was the first to report a lower relapse risk in patients who received a transplant with a double-unit cord blood graft compared to either matched-related, matched unrelated, or mismatched unrelated donor transplants in this collaboration between the Fred Hutch and the University of Minnesota. And these findings have been corroborated since then in an analysis at our center and in a more recent cohort from the Fred Hutch. I would also like to focus on some of the high-risk patient groups, starting with those patients who have minimal residual disease. Most people in the audience will be familiar with the Filippo's paper in the New England Journal, who showed that MRD-positive patients who receive a transplant with cord blood had superior survival compared to HLA-matched or HLA-mismatched donor recipients, and that was driven by lower relapse. There have been more studies since then, including a recent pediatric series from the UK and Ireland, which again showed that children that received T-replete cord blood had superior survival compared to other graft sources. And I'm also highlighting a paper from the University of Minnesota, which, in addition to stratifying patients by MRD, also stratified them by conditioning intensity. And MRD had no impact on the relapse incidence in those patients who received myeloablative conditioning, but not those who received reduced intensity conditioning. So although cord blood may in fact be very good for patients with MRD, conditioning intensity may matter. I'm quickly showing a slide looking at the impact of MRD on patient outcomes in an analysis from our center that we have presented previously in an abstract form. And once again, cord blood patients shown in blue had similar progression-free survival regardless of MRD status, whereas patients who received a sibling transplant or 8 out of 8 unrelated donor transplant who were MRD positive had inferior survival, and that was driven by increased relapse. Another high-risk patient group are those patients who are not in remission at time of transplant, and there have recently been 2 studies from Japan analyzing their outcomes according to stem cell source. On the left, you can see that patients who were not in remission and received the cord blood transplant had superior survival due to lower relapse compared to matched-related donor transplant recipients. And the same was shown also in patients who, in comparison to haplo-identical transplants, although here again the benefit was limited only to patients who received myeloablative conditioning. Again, suggesting that conditioning intensity may matter if we're trying to harness the GVL of cord blood. Finally, I'm showing some unpublished data from our center looking at 10 patients who underwent a cord blood transplant for a TP53 mutated myeloid disease. Most patients had detectable disease at time of transplant, and all of them had either complex cytogenetics or deletion 17. And we observed a 2-year PFS of 55%, which I think is respectable, considering that these patients typically have been associated with dismal outcomes. Again, the numbers are small, but I think the findings are still provoking. And I think what is important to note is that the biology of the GVL effect is not very well established. There have been many studies that have suggested potentially different mechanisms may be contributing. I will not have the time to go into those potential mechanisms in great detail, but I think that we can break them down thematically in 3 groups. The first 2 points have to do with the unique immune properties or the immune unique patterns of immune reconstitution of the neonatal T cells. Then we have factors related to the HLA-mismatch, maternal microchimerism, or lack of HLA loss. And then in the double unit cord blood transplant platform, there may be interactions, graft versus graft interactions that may potentiate the GVL. But certainly more work needs to be done to elucidate these mechanisms. The last point I wanted to make about cord blood as a unique feature is the immune reconstitution, because I think that cord blood had received bad reputation in the past, but that was based on a lot of studies that had used ATG or maybe suboptimal grafts. Here we show that in adults who receive ATG-free CBT, we observe early CD4 T-cell biased immune reconstitution, and this is thymus independent, so it comes from the T cells that are transferred with the graft, since the naive T cells come up later. So the CD4 T cells comprise the majority of the CD3s up until the 1 year post-transplant, and then in turn, in serial landmark analysis, we show that the higher CD4 count is associated with reduced hazard for mortality, so that matters in order to achieve good outcomes. So I think so far I have shown some data that supports that cord blood can be valuable for patients of ethnic minorities, can facilitate early transplantation, and can achieve good outcomes when modern strategies are followed, and can be associated with good immune reconstitution. Some limitations, however, remain, such as CMV infections and the relatively high rates of acute GVHD. So there have been some efforts to improve upon those limitations. One game changer, in my opinion, is the availability of letermovir. And when we started using it at our center, starting as early as day 7 and continuing for a minimum of 6 months, we saw complete mitigation of CMV infection in the first 6 months, and also there was lower burden of post-prophyalxis CMV infection. So it is a very effective strategy. It reduces mortality and morbidity and avoids the toxicity of CMV-directed antiviral therapy. But more work needs to be done to find the optimal duration for these patients. Based upon the findings that the higher CD34 cell dose was associated with survival and that letermovir is so effective against CMV, we have fine-tuned our platform at MSK, trying to optimize further the outcomes. So now the backbone is the same, but now we have more prompt recognition and treatment of acute GVHD. We have stringent criteria for graft selection, and putting a lot of emphasis on CD34 cell dose and unit quality, and using letermovir for all CMV seropositive patients. And we reported to the BMT last year an early analysis of the first 23 patients that had this optimized DCBT platform. What you can see here is that the median CD34 cell dose of the grafts that we used was quite high, although the HLA-mismatch was still 5 out of 8, which has been our median at our center for a long time. And with the caveat of short follow-up and small numbers, we saw very encouraging results of progression-free survival and overall survival of more than 90% at 1 year. A somewhat unexpected observation was that the grade 3 to 4 acute GVHD had come down from historical rates of 24% to 9%. And we hypothesize that this may have to do with the availability of letermovir that allows us to keep more robust cyclosporin levels early on, or maybe by other factors such as early intervention and treatment of GVHD when it is grade 2. But certainly the lack of TRM and low relapse rates made us very excited, and the fact that the grade 3 for GVHD was lower, and this has served as the platform for our current cord blood protocol at our center. Finally, I'm going to highlight a couple of efforts outside individual centers that the field has taken to further optimize cord blood outcomes. This was, here I'm showing you the 5 adult guideline papers and the 1 pediatric guideline article that that were published in the last few years. That was an initiative from the ASTCT cord blood SIG. And these are available for the community to be able to follow what we think is the current standard and replicate the good outcomes that centers of expertise can achieve. And I will finish my talk by highlighting some of the unmet needs and future directions, in my opinion, that we should take as a cord blood community. I think it is imperative to promote collaborations between transplant centers, maintain cord blood transplantation expertise, and also provide support to the public cord blood banks. And these initiatives can be achieved by the collaboration of many stakeholders, including the Cord Blood Association, CBAG for advocacy, but also with the newly founded Cord Blood Network that really tries to bring the community together. I think there is an unmet need for novel conditioning regimens, especially for high-risk patients, such as those who are older, comorbid, or need a second allo, and maybe triosulfan will have a role there if hopefully gets approved by the end of the year. There is also still a need to reduce the burden of acute GVHD without harming the graft versus leukemia effect. And some colleagues are already trying to investigate abatacept and whether this may have a role in this space. Also, I think it is very important to pursue correlative studies to try and elucidate more the GVL biology, because that could potentially lead to how we select a graft if we're trying to really take advantage of the GVL. And finally, I think there's a lot of excitement in the field about the development of cord blood-derived cellular therapies and maybe finding novel applications for either cord blood or cord blood-derived products. With that, I'm going to conclude my talk. And I'm not sure if we'll do questions now or at the end. Okay. Thank you.
Just right down. Sorry, right down there. Let me get rid of that step for you too. Right, one more. Nope, nope.
Good morning. Thank you for inviting me to Cord Blood Connect. It's my first time at the conference, and it's really a pleasure to be here. I will be talking about haplo-identical related donor transplants, current state and future trends, and I do not have any significant disclosures. Just as an overview, talk about the evolution of haplotransplants, selection of the optimal haplo-identical donor, and then a little bit about donor availability with different alternative sources. So I like starting with this graph because it shows you what has been happening since 1980. And as you can see, the numbers of haplo-identical transplants have been going up, as have fully matched unrelated donor transplants. Unfortunately, cord blood transplants have plateaued somewhat. And I want to review what has happened in the last 20 years, which has brought us to that point. So most of us are aware that fully matched donors typically produce better results in transplantation, and this has been shown many times in many different contexts. This is, of course, in the era of tacrolimus, methotrexate, cyclosporin, so the standard prophyalxis that we had probably 10 years ago. And I think it's no coincidence that Dr. Politicos and I have the same slide up early on in our presentation, that really in 2014, when this study was published, you could find a donor for 75% of Caucasians, but for everyone else, it was in the 30 to 40% range, which really was quite unacceptable. So what happened here? So HLA haplo-identical donors, this is a situation in which the donor and recipient share a single inherited identical copy of chromosome 6 containing the HLA loci. So this could be a parent, a sibling, 50% of your siblings typically could be haplos, or a child, or even sometimes more distant cousins if it's in particular instances. Unfortunately, though, early on in the 1970s, when haplotransplants were attempted, they were not very successful because of the intense bidirectional alloreactivity, which led to both graft rejection as well as graft versus host disease. And currently, there are 3 methods by which haplotransplants can be successfully performed. The first method was developed by the Perugia group, where they did T-cell depletion and then used mega doses of CD34 positive stem cells with very intense chemo conditioning as well as ATG. This led to low rates of GVHD, but poor T-cell function and high non-relapse mortality and infection. The GIAC protocol was with T-replete grafts, favored in China with methotrexate, cyclosporin, and MF as prophylaxis. Engraftment was excellent, limited relapse, favorable survival, but unfortunately high rates of acute and chronic GVHD, particularly severe acute and chronic. And then we came to post-transplant cyclophosphamide, which I do feel has somewhat revolutionized the field of transplantation in the recent past. So this is the famous Hopkins regimen where after conditioning with cyclophosphamide, TBI, and fludarabine with bone marrow product infusion, cyclophosphamide was administered on days 3 and 4, following which tacrolimus and MMF were also used. This strategy led to acceptable engraftment rates and low rates of severe acute and chronic GVHD with acceptable rates of relapse. There were some concerns regarding graft failure and infection, but a huge leap compared to prior methods of transplantation with haplos, which is what made it so attractive. And there has been a lot of work done on the mechanism of action of cyclophosphamide, and it's an ongoing effort. One of the leaders in this area has been Christopher Canacri, who's working on this at the NIH. And we do recognize that once the donor graft has been infused, there is activation of alloreactive donor T cells. The PT size seems to affect both alloreactive and non-alloreactive cells, but preferentially alloreactive cells, and also preferentially CD8 positive effector T cells with preservation of regulatory T cells. There also seems to be an improvement in both T cell number and function after the first 90 days, which may account for the slightly reduced toxicity of PT-Cy, even though there is additional T cell suppression compared to a conventional transplant. This was the paper that Leo Lasnik and others put out back in 2008. This was a combined study with the Fred Hutch, about 68 patients, and there were PT-Cy was used with 2 doses or 1 dose. As you can see, graft failure still was quite high, 13%, but low rates of acute and chronic GVHD. And I will point out that the relapse rate was quite high at 51%. And the overall survival and event-free survival were 36 and 26%. There were important landmarks in haplotransplant over the last 2 decades. Reduced intensity conditioning was considered one of the reasons why the relapse rates were high, and so myeloablative conditioning was used, which did lower the relapse rates and really was quite tolerable. Peripheral blood stem cells were used instead of bone marrow. There have been several studies comparing these graft sources with divergent results, but I point out one study which was in JCO in 2017 where there was similar overall survival, less GVHD, and more relapse with marrow product. However, I feel like I'm not sure if PT-Cy abrogates the differences in GVHD between marrow product and PBSC. There was then expansion of indications to non-malignant disorders, including aplastic anemia and sickle cell disease. And finally, the last 5 years has seen the extrapolation of PT-Cy to the HLA-matched and mismatched unrelated donor settings. We had BMT-CTN 1703 last year, where PT-Cy was significantly better at reducing GVHD-free, relapse-free survival compared to conventional prophyalxis with tacmethotrexate and reduced intensity HLA-matched donor transplants. Haplo-identical transplants are not perfect by any means. There are numerous problems that we encounter and which we are trying to combat. Increased risk of infections. This is likely related to the effect on the T cells that I previously spoke about. There is an increased risk of viral, bacterial, and fungal infections. Seems to be less of an issue with EBV, but CMV, adeno, and HHV6 are definitely issues. Cytokine release syndrome, which can be tackled easily enough with supportive care and IL-6 blockers. Cardiac toxicity, patient selection is particularly important here because the wrong patient will get very sick from a haplo. Hemorrhagic cystitis is not so much a direct effect of the PT-Cy, but has been found to be related to BK virus reactivation in the bladder. And finally, I think most concerningly, there is still issues with graft dysfunction, and we have had increased use of second cellular infusions. But overall, these are issues which we are tackling and making some headways with them. I know this is a cord blood conference, but I did have to show this study because it is a randomized study comparing cord blood transplants to haplos. I will point out that although the primary endpoint of PFS was similar between cords and haplos, cords were associated with lower relapse rates, but higher non-relapse mortality, and that's what really drove the poor overall survival, which was a planned secondary endpoint. So we recognize that there is a effect of cord bloods where relapse rates could be lower, but it's difficult to get the patients through the transplant safely sometimes because of the higher risk of non-relapse mortality. When we compare haplos to other kinds of transplants, haplos were compared to HLA-matched transplants in 2015, a very important paper from Steven Surya, where haplos with PT-Cy were compared to fully matched donor transplants with TAC methotrexate, which was the standard at the time. And there was similar overall survival between the groups with lower rates of GVHD with the haplos. We repeated the study in 2021 with PT-Cy being held constant as GVHD prophylaxis, comparing haplos and fully matched donors. In the reduced intensity group, there was lower overall survival with the haplos due to higher non-relapse mortality. In the MAC group, there was similar overall survival, but slightly higher GVHD. None of this was particularly surprising, and I think the differences are small, but still should be noted. And when haplos are compared to mismatched unrelated donor transplants, which I know Dr. Jimenez will talk more about, so far there is only retrospective data, and results seem to be similar. And I think the only way we can answer the question of which donor is superior would be with a prospective study, which is challenging to do. Selection of the optimal haplo-identical donor is important and could mean the difference between success and failure. And I think one of the factors that have emerged as probably the most important factor in donor selection is the role of donor age. This is an important study from 2016, which showed that with every 10-year increment in donor age, there was a almost 6% increase in the hazard ratio for overall mortality, and this was due to higher non-relapse mortality with older donors with no effect on relapse. This was replicated in haplotransplants as well, a paper from Amy Dizon in 2021, but retrospective single institution large analysis, almost 900 patients, but increasing donor age by decade was associated with poor overall survival for similar reasons as prior. And this is has been shown in several other papers, and this one also seems to indicate that if you consider even if you consider donor age, a fully matched donor is better than a haplo, but obviously a younger haplo is better than an older haplo. And this could be, the results of some of these registry analyses could actually be due to donor age. And we do see that the median age of haplo donors are typically higher than unrelated donors. This is data from Amy Dizon again. And so, you know, in real world practice, you often find a haplo donor who is actually older than the unrelated donor that you're considering, an evolving field. And extrapolating from this data, I think what is clear is that you should try and choose a young donor, whether you're using a haplo, fully matched, or mismatched unrelated donor. They also looked at donor age effect and kinship, and really donor age was more important than the relationship. Donor-specific antibodies have been one of the main problems in haplo-identical transplants. The presence of DSAs at the time of stem cell infusion increases the risk of primary graft failure, and it is important to identify this in advance, and the mitigation strategies are typically a combination of plasma exchange, rituximab, DARA, bortezomib, or IVIG. Our own approach to this is we measure the DSAs, and if they are present, we actually try to avoid that donor, whether it's a haplo or a mismatched unrelated donor. But if you have to use that donor, then you use mitigation strategies, or you should consider umbilical cord blood transplants. I think it's an important application of cord blood transplants even in this era where they have sort of fallen out of favor a little bit. CMV reactivation is another problem with haplo-identical transplants. This is actually a problem across the board with PT-Cy use, but in those who do get CMV reactivation, haplo-identical transplant recipients fare a little worse. Fortunately, my wonderful colleague Francisco Marti, who's not with us anymore, published this data in 2017 with letermovir, which really, I think, has temporarily solved our CMV problem. There are some late reactivations after stopping letermovir, but they do not appear to be that clinically significant. The effects of ABO mismatch are important, particularly in reduced intensity haplos, and when possible, we choose ABO matched donors over those with minor incompatibility, over those with major incompatibility. I think one of the important considerations in selecting a donor in this era of having so many options is which donor can you get fastest? And it is a difficult question to answer, and an attempt has been made to answer this question with BMT-CTN 1702, where with the donor search prognosis, you have a group where fully matched MUD is very likely, a group where it's very unlikely, and those in between. And the idea is if you see you're in the very unlikely group, you should pivot immediately to an alternative donor and not keep looking for a fully matched unrelated donor. In this study, 70% of these alternative donors were haplos, 15% were cord blood, and 15% were mismatched unrelated donors. We do not have all the results for the study yet, but we do have some top-line results, which are that there is no difference in the incidence of transplant or time to transplant, whether you were in the very unlikely or the very likely group. And I think this is important because we do have, it does show us that for whatever reason, somehow the time to transplant is not impacted as much as you would have thought. You would have thought a haplo donor is somebody you can get very easily and faster than a matched unrelated donor. And we're waiting for the final results of this study. We have become better at evaluating the effect of specific HLA mismatches, although HLA-DRB1 mismatches are associated with lower disease recurrence, HLA-B leader matching and HLA-DPB1 TCE non-permissive mismatching are associated with improved overall survival and so on. And we hope that we can further refine our donor selection in this manner. Donor availability considerations, I touched on it a little bit in the past, but I think the important thing to understand is that outside the United States, resources are much more limited than here. And so outside the United States, if you have a donor source which is practically as good as any other donor source, given the economic constraints and the resource constraints, that donor source will be preferred. And I think this has been the reason for haplo-identical transplants becoming the preferred alternative donor source globally, despite some of the toxicities and problems that I pointed out earlier. The one downside of that is that this has slowed the momentum toward establishing new regional registries or new cord blood banks, which is in some ways not a good thing, but I think some of this is being driven purely by economics and resources. Haplo-identical donors are readily available because they are family members, although with changing family structure and families being in many different countries, as we found in our practice, it's sometimes challenging even to get a haplo donor. And the NMDP did this study where they looked at whether mismatched unrelated donors would be available for those patients who had haplo-identical donors. And if you consider just the 8 out of 8s, the donor availability is not great compared to a haplo. But if you include the 7 of 8s, this availability goes up pretty sharply, which is also shown in this slide. That if you consider the 7 of 8s, which are these orange bars, you're going to get donors for almost 80 to 85% of your patients. And I think that is an important statistic. Antonio and I have recently published a retrospective analysis showing equivalency between outcomes between 8 of 8s and 7 of 8s, with all the caveats of a retrospective analysis. But I think it's important from this slide to understand that we now have many options. We have haplos, we have HLA-matched donors and mismatched donors, and we can refine our donor selection, and of course, there's cord blood. Future directions, optimizing haplo-BMT platforms, reducing toxicities by reducing the dose of PT-Cy. This has already been studied in actually outside the United States more, with pretty good outcomes, maybe a little more chronic GVHD. We are excited about combinations with PT-Cy. The CAST regimen, which includes abatacept, has shown some good results. And also adding ruxolitinib to a PT-Cy platform is being explored. Graft engineering to maximize GVL and minimize GVHD of these alpha-beta T-cell depletion has been particularly effective, especially in pediatric populations with high rates of leukemia-free survival and low risk of GVHD. Also, add back of regulatory T cells to improve immune tolerance was first really shown in haplos. Now, with ORCA T, et cetera, has moved to the HLA match setting. And naive T cell depletion to reduce chronic GVHD is another important frontier. So I'll stop with that, and happy to take questions after all the talks are done. Thank you.
Okay, thank you. And I'll be now presenting the data on MMUD and talk a little bit about how the use of, or the potential for MMUD transplants in expanding access to transplantation. These are my disclosures. And some of this background we have already touched on today. As we all know, allogeneic transplant curative for most hematologic malignancies. Outcomes are inferior when we use a mismatched donor. And a significant proportion of patients in the US lack an HLA-matched donor. And for those who are ethnically and racially diverse, there is a disproportional disadvantage. The use of all these 3 alternative sources are all viable options. And, but we have to remember that allogeneic transplant is an incredibly expensive, very resource-intense medical procedure, and therefore disparities in access are going to be, of course, prevalent. These are not just financial, they are a consequence of healthcare system issues, provider bias, cultural, social factors, and of course biological factors, which is what we're mostly focusing on today. And when we talk about disparity, in terms of access to these fully matched donors, it's important to look what that disparity looks in figures. And again, this is slide we're all familiar with, but I think it's important to remember the likelihood of finding a fully matched donor, an 8 out of 8 for a Caucasian patient is 80%, and that number drops to less than 30% if that patient is Black, and less than 40% for a Hispanic patient, and numbers are even lower for a very mixed patients. But if we are permissive, again, to higher degrees of mismatch, we have the potential to identify a suitable donor to every patient, irrespective of the race. While the use of mismatched donors for these patients is an option, we do know that historically, we pay a price for each degree of mismatch. We can see here with traditional CNI or GVHD prophylaxis, any transplant, 6 out of 8 or less, is essentially prohibitive because of high rates of GVHD and non-relapse mortality. So there continues to be an unmet need to expand access to transplant, especially for these patients who are racially or ethnically diverse. I'm obviously not going to spend any time talking about cord and MMUD because my colleagues did a fantastic job talking about the advantages and disadvantages of each graft source, and we have to understand that there's nuance, and I think for all alternative sources we have come up with ways to optimize transplant delivery. As Shweta was mentioning, haplo-identical transplant, especially at a global scale, has become perhaps the preferred donor option when we talk about alternative transplantation for issues of logistics and financial advantages. But on top of the normal barriers that we discuss, and there's of course the issue of donor age, which we know that increasingly it's an incredibly important factor predicting transplant outcomes. The presence of DSAs, which, when we are using a haplo-identical donor, we are somewhat limited in really choosing a donor with no antibodies, germline predisposition in families, and a very important one that we see often is logistics. Many of us who trained in the haplo era, we hear this mantra, everyone has a haplo donor, or most patients have a haplo donor. And what that might be true biologically is not always true logistically, particularly true for patients who are, again, ethnically or racially diverse and immigrants. We have 70% of our patients here in Miami, for example, are Hispanic, and the challenge sometimes is not a biological or medical one. It's really saying you can have a young patient that has multiple haplo-identical donor options back home, whether that's Colombia, Venezuela, Nicaragua, but really logistically it's just not possible to have that donor travel to us or achieve these collections locally. So when we think of these problems, then of course, are there any other alternatives for these ethnically, racially diverse patients without a compatible donor? So in an effort to improve the outcomes of mismatched transplants and to expand transplant access, the NMDP sponsored 15-MMUD. This was a phase 2 trial conducted at 11 centers. We have 80 patients, 40 receiving reduced intensity, 40 receiving ablation. This was a non-randomized trial. This was allocated at investigator's choice. We use MMUD graft, 7 out of 8 or less, with the use of a bone marrow graft, and GVHD prophylaxis, PTCy, 50 days 34, in addition to sirolimus and MMF. We hypothesize the survival at 1 year following this transplantation will be 65% or higher, comparable to what was reported in haplo-identical bone marrow grafts, with most patients achieving adequate engraftment, near full donor chimerism, and acceptable rates of acute and chronic GVHD. I want to bring your attention to this figure here, and that is that nearly half of the patients that participated on the trial belong to ethnically diverse backgrounds. And for a unrelated donor transplant, a prospective trial, that was truly unprecedented. And I think it was one of the first hints of the potential of MMUD to, again, expand transplant access. And a second figure that is important here to the left is 1/3 of patients, more than 1/3 of patients on the study receive a highly mismatched graft, that is a 6 out of 8 or less. And that is important because if we are permissive to that degree of mismatch, as Dr. Gupta showed before, we can potentially identify a donor for any patient, irrespective of their ethnicity and race. But more importantly, we can optimize some of those non-HLA factors she was referring to. By having a larger donor pool, we can optimize age, which we know is incredibly impactful, ABO, CMB, et cetera. So not only we can identify a donor for any patient, but we can find potentially a better donor for that particular patient you are evaluating. The study met a primary endpoint with a survival of 76% at 1 year. And importantly, we found no difference based on degree of mismatch or the race or ethnicity of the patient. We have low rates of acute and chronic GVHD, 9% at 100 days, and 4% for severe chronic GVHD, and non-relapse mortality, 9% at 1 year. We compare survival and other outcomes to historical controls receiving a haplo-identical transplant, bone marrow and peripheral blood, and peripheral blood MMUDs, and again found no difference in survival or any other outcome. The main factor that drove worse outcomes was donor age over 35 that resulted in higher non-relapse mortality, and we have seen this replicated in many other studies. And so the study concluded that approach was feasible and safe, and with outcomes would appear comparable to other settings where PTCy was used. But perhaps the most important finding to me is that with half of the patients being ethnically diverse, again, one of the first hints that of the potential of MMUD to again expand transplant access across racial barriers. We evaluated outcomes 3 years out, and again, at 3 years, survival is still over 65%, non-relapse mortality of 12%, and again, severe GVHD 9%. Also importantly, we found no difference, again 3 years out, between patients receiving a single antigen mismatch, 63%, versus those receiving 6 out of 8 or less, 71%, which gave us some early reassurance that the transplant could be expanded safely for patients without an 8/8 or single antigen mismatch. A couple of questions, some of these we have discussed already today. Is there a preferred GVHD prophylaxis for patients receiving an MMUD? And up until that study, our historical standard was ATG. For the first group to address this question was EBMT, and they looked at a matched pair analysis, PTCy versus ATG on patients with acute leukemia. This was for 9 out of 10 patients. And they found lower rates of GVHD, better leukemia-free survival, better GRFS, and a trend for better survival in patients receiving PTCy. We evaluated the same question in our cohort at University of Miami in a collaboration with our colleagues from Sloan Kettering, 128 patients, all receiving mismatched graft less than 7 out of 8 or less. And again, we compare PTCy to our historical standard of ATG methotrexate. 2/3 of the patients ethnically diverse, and 1/3 of patients on the PTCy arm were highly mismatched. Again, 6 out of 8 or 6 out of 8 or less. We look at GRFS, similar relapse rates, but really the similarities ended there. Non-relapse mortality more than twice in patients receiving ATG, resulting again in better overall survival and better GRFS for patients receiving PTCy. The leading cause of death was a relapse of the primary disease for both groups. And while we saw similar lymphocytic reconstitution, we found better B-cell reconstitution at 12 months for patients receiving PTCy. We didn't have enough power to look specifically at difference in rates of CMV or BK or adenovirus, which were the most common infections. We found that despite higher degrees of HLA mismatch, the use of PTCy following MMUD resulted in better clinical outcomes that appear comparable to what's reported in haplo-identical and even matched unrelated donor settings. And it seems to be a safe and effective alternative for, again, ethnically diverse patients. Perhaps two more contemporary questions. It's how does MMUD in the era of PTCy compare to other graft sources? There has been many comparisons, some of them already shown today, comparing MMUD to haplo, comparing MMUD to cord blood transplant. I think it's very tough to tease these comparisons because there are so many covariates for haplo-identical transplant. Even for cord, we have seen studies showing equivalent results, some of them favoring MMUD, some of them favoring haplo. And I just want to discuss a couple of studies today. One, this was very recently published, and interestingly, they looked at granular factors that we are trying to understand a little bit better today. And this was a study from the CIBMTR looking at 3,000 patients, comparing haplo-identical to MMUD, specifically looking at PBM, B-liter, and class II antigen mismatches. And essentially what they did was they stratify MMUDs on the basis of PBM match and haplo-identical transplant on the basis of B-liter sequence matching and DRB1 status. And patients receiving a haplo-identical transplant, B-liter match and DRB1 mismatch outperform all other groups. All these theories, I think it's important to remember that donor age, again, was the most important factor for outcomes and really trumped everything else. And another important caveat is that all MMUDs in this trial receive CNI-based prophylaxis. So whether that's applicable to MMUD that we're transplanting today, that most centers will favor PTCy or a clinical trial, it's unknown. And this is a question we are currently addressing at the CIBMTR level. A second question, how does MMUD fare compared to 7 out of 8? This is a study we recently published, and we looked at, again, MUDs 8-8 versus MMUD 7 out of 8 using a PTCy or a traditional CNI-based approach. 10,000 patients, again, MUD with or without PTCy, MMUDs with or without PTCy, and we look at 3-year survival in GRFS, and not that many surprises. So for both groups, MUD and MMUD, PTCy resulted in better outcomes, better survival in GRFS for the 8 out of 8s, and better GRFS for the MMUD. And we found this advantage to be consistent across races and ethnicities. But more importantly was that we found no difference in survival and GRFS when we compare 7 out of 8 versus 8 out of 8 with PTCy. And this, of course, has important implications on expanding transplant access safely. 15 MMUD, I think we have to remember that while was a very important study, was a small trial, 80 patients, and it was conducted at 11 centers with expertise in MMUD and haplo-identical transplantation. And I think it's important when we're trying to assess a strategy looking at expanding access, it's important that this strategy can be replicated at a much broader level in a much more heterogeneous population, also including pediatric patients. And the few other questions, I don't think we'll have time to go through all of them today, but look at ways to optimize the delivery of PTCy and look at alternative or even adjunctive therapy to improve some of the toxicities that we continue to see. The first questions we're hoping to answer with access, another phase 2 study sponsored by the NMDP, and again looking at the PTCy platform in patients receiving peripheral blood graft for adults and bone marrow grafts for pediatric patients. We're looking at survival at 1 year following transplant. And we have 3 strata based on intensity and age. Stratum 1, adult patients receiving ablation. Stratum 2, adult patients receiving reduced intensity. And stratum 3, pediatric patients receiving ablation and bone marrow graft. Initially, we predicted a participation of 180 patients, but accrual in the reduced intensity conditioning far exceeded expectations, leading to modifications on the protocol and increased that to 190, which I think it's a testimony of how the use of MMUD as an additional option, it's hopefully fulfilling a gap in need transplant. We completed accrual for both adult cohorts, and what I'm going to be presenting is the data for the first 70 patients on the RIC that we presented at ASCO and EHA. Inclusion criteria, I'm not going to spend much time here, very similar to what how we enroll patients on 15 MMUD, with only the difference, of course, we're using a peripheral blood product, and we change our threshold for DSA. Standard schema of PTCy in days 3 and 4 at standard dosing, followed by TACR and MMF. And 70 patients, 13 centers with a median age of 65. Remember, this is a reduced intensity group. Importantly, 51% of patients identify as racially or ethnically diverse. Most common regimen Flumel, and AML was the leading indication for transplant. Median donor age 25, and importantly, 1/3 of patients again receive a 6 out of 8 or less matched graft. Survival at 1 year, 79%, which was essentially identical to what we saw on the 15 MMUD reduced intensity group. And other outcomes were equally satisfactory, with GRFS of 51%. Severe acute GVHD 3-4 and severe chronic GVHD both 9%, non-relapse mortality 13%, and a relapse rate of 21%. And importantly, we found that outcomes were essentially comparable to every other outcome on the 1703 PTCy arm. An important observation, we still observed 50% of patients at 100 days had increased rate of infections that presented grade 2, that presented really an opportunity to improve outcomes by improving infection-free survival. And that's something that we're looking in right now. But in conclusion, we found encouraging survival and post-transplant outcomes following transplantation that gave us a signal that the use of these graft source with peripheral blood and this approach has the potential to expand access to transplant to all patients in need of an allograft. Again, we have completed accrual for adult patients. Pediatric cohort is still enrolling. We found no difference between single antigen and highly mismatched graft, but this is again only on 70 patients. We need more data. And currently ongoing efforts are looking specifically at target improvements in infection, GVHD, and relapse rates. One of them is the optimized study. As it was briefly mentioned before, probably not every patient needs the higher dose of cyclophosphamide. We're all familiar with the known toxicities, cardiotoxicity, and liver toxicity, and again, it's very possible that not every patient will really need the 50 milligrams. We have data from the haplo-identical setting that this appears to be safe and feasible. And so this study is specifically looking at the question of reduced doses of PTCy, patients receiving a running phase of 37.5 with an idea of treating patients at a dose of 25 milligrams. And I think it will be important to also understand if these reduced dose could be tailored to other factors that we have evaluated in haplo-identical and MMUD transplant, such as class-specific mismatches, class 2 mismatches, PBM. But again, these are all things that we are currently trying to understand a little bit better. We have a total of 187 patients expected to enroll. To date, 60+ patients, exceeding accrual by 60% of what we forecasted. Again, I think a testimony of the importance of the graft source and the need that is fitting. And 62% of these patients considered to be ethnically and racially diverse. because of ASH embargo rules, I really can't share much more about the trial, but I encourage you to attend the presentation on ASH in December. In summary, despite increased transplant utilization, again, access continues to be an issue, and the use of alternative source, not just MMUD, but haplo-identical and cord blood transplant are, of course, all viable options. MMUD results so far appear to be comparable to what we see on haplo-identical and even 8 months, but there are new approaches that continue to be explored. We talk about graft engineering, the very recent nice data with CAS. We would like to know a little bit more about that in the MMUD setting, CNA, free combos, and again, a couple of prospective trials, ongoing right now. One important factor is that even when we allow this highly mismatched graft, I think an important observation continues to be that patients and donors share the same race and ethnicity. So despite the ability to use highly mismatched grafts, the participation of ethnically diverse patients in the registry is incredibly important. And we mostly address biological barriers to transplant when we look at matching, but there are many other barriers to transplant access that are required the same level of attention. And with that said, I want to thank you, and we'll be happy to take any questions.
Hi, this is Mitch Horowitz from Duke. Thank you for 3 terrific talks. As a cord blood advocate, I admit I still do other alternative donor transplants. Not a lot of mismatched unrelated, but haplos. What I'm seeing in the mismatched unrelated space is sort of a replication of how haplo developed, which is that the prospective studies that are done using bone marrow grafts, and then once we figure out it's working, everybody starts to move to peripheral blood. And there are big differences in the 2 graft sources. So what are your thoughts on where we should be, how we should be doing these transplants, despite the fact that their bone marrow grafts seem to be the preferred in the early stages of development?
Can you hear me? Yeah, okay, perfect. Yeah, a very good point. And I think, the way the trials were designed, that progression was done by design, again, replicating some of the experience with haplo. I think it boiled down, again, the decision to move to peripheral blood boiled down to logistics. And I think as we learn more from these ongoing trials, access, again, optimize and accelerate, which is a future trial, I think decisions about choosing an optimal graft source, meaning a bone marrow versus peripheral blood, we'll have more information to make those decisions. I think the decision to move to peripheral blood was, again, one of more to try to study this at a broader scale, and we know that it's peripheral blood is the preferred choice by most centers. And so far, at least, what we find encouraging, the retrospective data, you have to always take it with a grain of salt because there's too many confounders, but at least in what we have so far prospectively, I mean, as I showed, the results for reduced intensity conditioning, everything else being equal, they look identical. We, of course, need more follow-up, we need more data, but that was essentially the reasoning for it.
Thank you very much for your talks. A question for the haplo donor. There's more and more data that's come out that suggests that donor age is extremely important and it clearly affects overall survival post-transplant. Where do you put your cutoff for donor age for haplotransplant? And my second question is, how much do you take into consider B-leader match, mismatch, DP match, mismatch, because that clearly affects overall survival as well?
Thank you. Yeah. The way we approach it is if you have the NMDP cutoff for an unrelated donor is now 35 years old. So if I have a haplo donor who's even younger than 35 and I'm doing a myeloablative transplant, I will use the haplo donor. But typically your haplo donor is older than the other alternative, which is a mismatched unrelated donor or a fully matched unrelated donor. So I would say my cutoff depends on the age of the alternative donor that I have available. But in the myeloablative setting, I feel very comfortable using a young haplo donor rather than a, fully matched unrelated donor if that is taking too long or something like that. So 35, but depends on the other alternatives that you have. And yeah, we do take into consideration HLA-B leader mismatches when we are selecting if we have options between numerous haplodonors. But often you don't have that many haplos to choose from, as you would imagine. So we do take that into consideration for donor selection.
And a question for Dr. Jimenez. I have a question regarding the mismatched unrelated donors. The CIBMTR published data that with PT-Cy, it really abrogates the difference between, survival between an 8 out of 8 and a 7 and 8. The EBMT presented data suggesting despite PT-Cy, a 9 out of 10 still had an inferior overall survival compared to a 10 out of 10.
Yeah, it's a very good question. I think it's very hard to compare two trials, for a number of reasons. Their definition of matching is MMUD, they're looking at 9 out of 10, we're looking at 7 out of 8, but I don't think that's the main. We look also, patients were treated in different eras of treatment, so we on purpose decided to go with a smaller cohort so we could include patients treated from 2016 and now the data from EBMT started enrolling patients, if I remember correctly, 2006, 2007, and the use of T-cell depletion on the EBMT cohort was significantly higher than what we saw on our CIBMTR cohort. I think, like near to 70%, so, and I think last but not least, I think an important observation is to say that, and mind you, the difference in survival might have been statistically significant, but the numbers were not that different. And I think, the both studies were presented on the same journal at the same issue, which I think it was, of course, a nice way to promote that discussion. And I think it brings another important point, which is the necessity to also collaboration within registries. We are treating different patient populations. They also use different criteria when looking at GVHD severity. So, I think it's very hard to compare apples to apples. I believe our data has a more contemporary treated patient population, a lower use of T-cell depletion that is more consistent with the practices in the US. But again, I think it highlights the importance of collaboration within registries and looking at data sets that were essentially very different. But a very good question, thank you.
Okay, thank you all. These were very good summaries of the current literature and very interesting talks. So I have a question about the mismatched unrelated studies. In the first study that we have some longer follow-up, it seems that the relapse rate is going up and up per year. And I don't think that's addressed enough. Let's put it like that. So perhaps one important question there is the MRD of patients that went into the study. From one Dr. Politicos presented, there are very good data on cord blood and MRD positive patients. So perhaps that's a population that needs to be studied further, whether they would benefit from a mismatched unrelated.
Absolutely. I think one point that I didn't, because of time, I didn't elaborate much on that. But is remember that we have 80 patients. These were not randomized patients. So we had, and when you look at the composition, the breakdown of the patients, they were dramatically different. So the relapse was mostly driven, surprisingly, by the myeloablative arm, and 80% of these patients were patients with acute leukemia. I think I also being involved in the study from the very beginning. I think there was a lot more hesitation. It took time to enroll in this trial. And again, COVID got on the way, but when we look at the patient population, these were patients, if someone, like 6 years ago, if someone was willing to put a patient on a trial with a 6 out of 8, these were patients that didn't really have many more options. So these are patients with very high-risk leukemias. Some of them absolutely in MRD. Our criteria for inclusion was just to be morphologic remission. For MDS, you don't even need to be, you can be up to 10%. So, and again, we don't have granular data about genotype and MRD, and again, of course, that's not standardized. But I suspect that the higher rates of relapse that we saw much more on the ablative arm had more to do with patient selection and the patients that were being sent to that trial with a highly mismatched graft early on. But of course, it's a very important point and something that we're looking specifically in access and optimize.
That's great. And further on, there are a lot of studies addressing the loss of HLA and relapse in haplo-transplants. It might be worth studying these patients also. There may be a different mechanism.
We're looking into that too. That's a great point. Thank you.
Hi. Firstly, absolutely fantastic session. I really commend all the speakers. It was really outstanding. And sort of a comment, having been in this field for over 25 years now, I think that it's important to recognize that the problem in the field has been over decades. There's been actually a lot of polarization and actually toxicity, but sort of between different advocates of different stem cell sources. And I could give you a multitude of examples, which would probably be better over wine at the bar. But it's been pretty unpleasant, actually. And initially the sort of double cord came in, it was the sort of flavor of the month, and then the sort of haplo swept in, and there was, it was a major advance in the field, but there wasn't really any acknowledgement that not everyone has a haplo. There are problems with the haplo-transplant platform and PTSI, which you completely acknowledge. There are also major problems with cord. And then now it's like haplo sort of, many centers have just stopped talking about haplo, and now it's mismatched unrelated, which has also been a landmark game changer in the field. But the point being is that there are problems with mismatched unrelated. For example, independent of the match grade of the donor relative to the patient, you can model what's in the registry, but from a logistical standpoint, the donor has to turn up. And the majority of allografts are done for high-risk myeloid malignancies. Often the patients need to go fast. And if you're a minority patient, there's late referrals. It can be a lot of psychosocial, socioeconomic things that have to be sorted out there. Underserved patients can be more complicated. And you have to have a donor that turns up quickly. And so we're going to have to change how we do the searches and the activation of the donors to be able to get one in the time needed for the patient. Otherwise, all those patients will drop off because they'll relapse and blow through. They'll never get to transplant, and then they're unseen. But the point is that if you make these statements, then you get criticized because people say, well, MSK and Fred Hutch cord blood data can't be replicated. It can. They'd say, well, you're saying everyone needs cords. No, I'm not. There are many patients that don't have cords or will do badly with cords, on you go. But the point being is that to serve the patients, we need all stem cell sources. That's the bottom line. We've got to have everything. And I think that the patients will be best served if we do have access to the expertise to be able to do transplants with all stem cell sources. It's going to be really hard, actually, in retrospective studies to be able to tease out sort of like the decision-making sort of journey as to sort of which patients will do best with which stem cell source in which situation. But at the end of the day, that's actually really in reality what will be needed. And there are some patients that either won't have access to A, B, or C, or will do better with A than C. if you get what I mean. So at any rate, I would absolutely try to advocate for a truthful representation of the pros and cons of each, and the fact that particularly with the young investigators in the field, don't make the same mistakes that have been made historically when the field has been polarized, saying, well, now, everyone has haplo, so you don't need anything else. Or now it's everyone has mismatched unrelated, so you don't need anything else. We need everything. That's the bottom line.
Yeah, that's a really good point. And I couldn't agree more. I'll just add to that. I think, and when we were putting the session together, I think that was kind of like the flavor that we wanted to share. I think oftentimes a lot of some of these trials are written, or even when they ask you to write an editorial or write some sort of, there's always this spinning sources against one another. And I think the whole idea of the session for us was to present all three sources as viable. I think to your point, I think there's a number of patients, there's data that is not presented, and those are patients who don't make it to transplant. And it's like, how are we serving those patients,
Right.
and to see it in your, like MMUD or haplo or cord, like Castle, and say, this is what we do. It's obviously, if we recognize that all sources are viable and there are indications where, one is going to be truly better than the other, everyone wins, and most importantly, patients benefit. I'll share a quick anecdote. Like last week, they have the ICH meeting in Monterey, and I was invited to talk about MMUD. And I come here talking about all that we have done and access, and we share some of the like lab work that was done. And I was very humbled because at the end of the day, the meeting was in Monterey, Mexico. When everything was finished, the speaker goes and say, "This is all great, but in reality, such a minority of patients have access to this. This is a haplo town. We really can offer MMUD to all these patients." And I think it brings that point. I think you have to look at everything in context. You have to think of center expertise, urgency of transplant. We do a lot of work on MMUD, but if I have a patient that needs to be, it's leukemic aplasia, and I don't have time to get an unrelated donor, that wouldn't be the right thing to do to get an MMUD for that patient. So we're completely aligned on that.
Yep, thank you.
Yeah, I couldn't agree more. That was a fantastic session, all of you. I wanted to just bring up a little bit about graft versus leukemia, because I think all of us who transplant patients, we know those who relapse after transplant, right? It's hard to salvage them. We do, but their chances of long-term survival go way down. All of you sort of showed data on relapse risk, and Yanni, I guess I would ask you, it's terrific to get all the questions about mismatched and the other, but in the cord setting, I wanted to see what you could talk about in terms of what is the research going on. We're going to hear some talks later in the conference about the graft versus leukemia and cord bloods, but I really want to encourage people to start thinking about that. What are things that we can do to enhance the graft versus leukemia effects?
Yes, I think this is a very, very important question, and I think more work needs to be done. I don't think that we have fully understood the mechanisms, and there may be more than one mechanisms. I think it's beyond just the degree of HLA mismatch. There was a large paper from Japan last year looking at the impact of the locus of HLA mismatch. So we know that class 2 mismatch seems to have less relapse. Mismatches at the A locus may have less mismatch. There is also a lot of provoking data in terms of graft versus graft interactions, whether that the second graft is a cord blood unit or granulocytes or an expanded product. There is certainly lack of HLA loss. I don't know if that contributes and to what degree, because in theory there could still be a chance for epigenetic downregulation of HLA in the setting of cord blood, but certainly the genetic loss of HLA is not a factor in cord blood, as we have seen data by Luca Vago. So I think there are maybe multiple factors, but if we understand that better, then we may have a chance to deliberately select a unit in a way that will maximize the GVL. Maybe, prioritizing a specific locus of HLA mismatch, or maybe like a double mismatch at an HLA locus. I don't have a perfect answer, but I am excited to see new data.
Yeah, and I think it's really important to encourage all the young investigators in the room and to get more research around this, because I think it is one of the most pressing issues. And the granulocytes, I'm super excited to see Rob Wynn's presentation around that.
Absolutely.
But in the United States, that's not a practical approach, right? So we have to think of other things. And I think there needs to be some lab work that's, models the PT-Cy and haplo. And the other thing is, you guys are all leaders in this space, and I think we all agree centers have biases, right? Like you were just talking about. The thing we really need is a prospective trial that really looks at all graft sources, and I don't know why that's so hard to do, but hopefully all of us can try to think about how do we include all sources, all alternatives. Everything really beyond a mud, right, is an alternative donor. So hopefully we can see some trials that include everything, so we can try to figure out what's best for patients.
Absolutely.
Thank you very much.